Hi, this is Junaid back with another lecture on acute ischemic stroke, 2019 guidelines. In this lecture series, we're going to start discussing about IVtPA. This is divided haphazardly a little bit if you look at it, but at the end of the day, it makes sense when you go through these lectures in a series to understand what is the indications, the contraindications, and the time windows for the IVtPA. Acute ischemic stroke guidelines are divided into 6. This is the part 3 that we are discussing, and more specifically, we're discussing part 3.5, which will be generally speaking about IVtPA. One of the key features that you have to understand is that IVtPA needs to be given as soon as possible. Acute ischemic stroke patients do not have time. We start losing neurons, about 6 billion neurons per second, as we move along as far as the patient's brain is not getting the blood flow, oxygen, and glucose. So time is very, very paramount. And if you look at the level of evidence, it's A, and the class of evidence is 1. The second thing is that all emergency physicians should be prepared for adverse effects. And one of the key adverse effects that can happen is angioedema. So you actually need to have a cart ready around, or in the ER, there is a possibility that if you have to suddenly intubate the patient or do even an emergent cricothorectomy, you are ready for it. So it is important that this is something that has reasonable amount of possibility of things going wrong. So therefore, you should be prepared for it, and there should be systems in place that, when there is a stroke patient, a TPA patient, you are ready for potential side effects. Now, the third point, that the patient's risk of getting TPA needs to be discussed. Now, when you have standard of care, you are allowed to give medication. Now, if, for example, the patient is coming alone, there's no one at bedside, but, the EMS clearly suggests that the wife told us that this started about 20 minutes ago, and the patient is aphasic. Can I discuss this? I can't. And if you can't, then that's all right. But if you have the possibility of having a discussion, it is always a good idea. In general, even aspirin, for God's sakes, because patient can fall, hit their knee, and can have hemarthrosis. There's always nice the patients are understanding the risk they're getting with all these treatments. So clearly with TPA, if you have the reasonable chance of having a discussion, have a little bit of a discussion. Do not delay things for actually having the discussion or getting the consent. It is standard of care, and therefore there is no consent that is needed. What is discussion is always good, because that actually tells them that what they're getting into and what to expect. So clearly that is always a great idea. More importantly, you have to understand that hypoglycemia and hyperglycemia needs to be evaluated. That is the only one test, technically speaking, you need. Very severe hyperglycemia can mimic stroke, so does hypoglycemia. And therefore, before initiating TPA, you need to make sure that the patient's glucose levels are within normal limits and treat it accordingly. One of the things that I've noticed is that the patient might be improving. I don't know, and I don't care. To be honest with you, there is no reason to monitor for improvement. I mean, if there's a significant improvement already happened, that, for example, the patient had an AIS stroke scale, was barely able to breathe with an AIS stroke scale of 19 at home, and now comes in with an AIS stroke scale of 5, that's a very different situation. The question always is that you're not going to sit on your ass and say, you know what, I'm going to sit here and see if the patient improves and then potentially give TPA. That is not the case. The only, of course, the issue is hypoglycemia, and at that point in time, it's a frank contraindication. There's no middle ground there. So at the end of the day, what I'm trying to say is that do not delay TPA for especially monitoring for improvement. Believe it or not, this used to happen a lot because people were scared of TPA. Now, of course, things have changed. Now, as far as the TPA is concerned, the time window, if you look at the class of evidence and what are their recommendations, very simple. Within 3 hours, maximum 90 milligrams, 0.9 milligram dose, and bolus, and then the rest in the infusion. Level of evidence is A, class of evidence is 1. Between 3 to 4.5 hour window, if you look at the level of evidence, it's actually B. What is the class of evidence? The class of evidence is 1. What we found out is that if the patient is eligible, and we're going to have this whole discussion in the eligibility criteria, please give TPA, because the chances of patient improving with TPA is much larger than the symptomatic intracerebral hemorrhage that we are all concerned about. So less than 3 hours, no questions asked. Between 3.5, 4 hour window, according to the class of recommendation, if the patient is eligible, no questions asked. Now we come to the new one. This is the discussion that we had the last time as far as, providing how we're going to stratify patients as far as acute ischemic stroke workup. If the patient is unknown time of onset, has a flare and DWI mismatch, and is less than 1/3 of the territory of MCA, then you should consider giving that patient a TPA. The class of evidence over here is 2A. Of course, there's not enough studies to actually, recommend this at the level of level 1. But at the end of the day, if even the DWI lesion is there, it is 1/3 of the territory, but the flare is not there and there's a mismatch, the patient should get TPA. Now, of course, there's a concern that most places cannot have that rapid of an MRI. The MRI also itself delays it, and the patient's symptoms do mismatch or not as well. Because if the patient has 1/3 territory and already has expressive aphasia and all that, but at the end of the day, if there is no flare, if the time is unknown, you should give TPA, and the class of recommendation is 2A, which is pretty decent. In patients with sickle cell disease, it is beneficial, give it. In the patients with hyperdense MCA sign, it is beneficial, give it. I don't know why these need to be separated out, but at the end of the day, people, I suppose, had done some clinical studies and these needed to be included in the guidelines. Of course, clearly, if there's an MCA hyperdense sign, we're going to give TPA. Again, grateful for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.